Hi, everybody. It's a pleasure today to introduce Professor Manish Kohli, who's been a wonderful collaborator over the years working with us. And we thank him for joining us here today. And he's started his clinic at the VA at the University of Arkansas and as an assistant professor, and joined the University of Rochester, New York as an associate professor in 2005. And he joined subsequently to Mayo Clinic in 2008 to build a comprehensive translational and clinical research program. And he was promoted to professor in 2016 and 19 and appointed as vice chair of the Department of Oncology and as a distinguished Moffitt scholar. Here, we would like to welcome him from the Huntsman Center today, where he's joining. And I met with Manish many years ago when he visited Stanford, where he was invited to give another wonderful talk. So we are very excited to have you on board and look forward to hearing from you.
Thank you. Thank you very much, Utkan, to have me here for the presentation. I value our collaborations that have been going on, and I'm looking to many such productive ones in the future as well. So let me launch into the title of my presentation, which is to do with biomarkers, convergence sciences, and the treatment landscapes in advanced prostate cancer, which is where I have clinically I focus on in terms of clinical oncology. That is my bread and butter beyond the research part that I do. My disclosures are listed over here. None of these affect today's presentation. Let me summarize by looking at the landscapes in advanced prostate cancer for you first, in terms of the treatment and the clinical trial landscapes. Then I'll move quickly on to what are the overviews of the biomarker landscapes and some of our work, especially in circulating tumor DNA. I'll follow that up very briefly with machine learning applications and biomath applications to these biomarkers in advanced prostate cancer. And finally, I'll work again a snippet of that, given the shortage of time, on bioengineering applications over here. Finally, I will bring it home with trying to understand where the niche of science is still missing in terms of increasing clinical value to science and applying it to the patient by way of cost effectiveness. And I'll try to make the case for convergence sciences. So, advanced prostate cancer can be divided into early stage local prostate cancer. And then, when it metastasizes, it becomes metastatic prostate cancer with hormone sensitive disease. And after that, it becomes clinical castrate resistant prostate cancer when our treatments fail in the hormone sensitive state, which is primarily treated with taking testosterone away, which is androgen deprivation therapy. In the castrate resistant state are listed some drugs over here for you, which include chemotherapies, as well as radiopharmaceuticals, as well as novel hormonal agents. In the last 15 years, we have seen a absolute mushrooming of treatments over here. But what we have also seen is that these treatments have increased our ability for patients being treated and living longer from about 18, 17 months in 2004 to about 36 months now in these last 20 years of these new treatments being given in castrate resistant state. So there's been some incremental progress. At the same time, what has also happened is that these very drugs, which we use in castrate resistant stage, which is after the failure of androgens deprivation therapies, these have graduated to the earlier stage of hormone sensitive disease, where all these drugs are now combined with androgen deprivation therapies. And there are doublets and triplets now being given when only androgen deprivation therapy used to be given until 2015. So that in the last 7 years, we have seven new FDA drug approvals in this stage, and we are truly confused of what drug to give to which person as such. And so the good part is that while in 20 years back, At 5 years, 25% people used to live with androgen deprivation therapy alone. Now, with these doublets and triplets and intensification in hormone sensitive state, people are living longer, and they're living up to 5 years on an average or more. But the bad part is we don't know how to choose one treatment over the other. We have got seven of these treatments, and right now we choose on the basis of pros and cons, which are very clinical estimates. Like, um, is the patient going to have treatment toxicity like febrile neutropenia? So don't give that patient chemotherapy. Give that patient the other agents, which are also FDA approved, like abiraterone. Is the patient not able to give the insurance co-pays because these new drugs are very expensive? So give chemotherapy. That's how estimated values are that in the clinic with the patient that we struggle with. And so those are the trials of the past. In the future, more of these combinations are becoming prevalent. And one of the things we have noticed is that there is a beginning of chemotherapy agnostic treatments coming, which in other words means that targeted treatments are beginning to come, some of which are listed over here. Drugs like rucaparib, talazoparib, abemaciclib. The first two are um, PARP inhibitors. The third one is the CD4/6 kinase inhibitor, and all others listed over here. So, in other words, we are beginning to go from clinical to biomarkers, and we are beginning to target biomarkers which are specifically altered in this tumor biology. So that takes us into the concept of one of these drugs, which is PARP inhibitors. Now, as you will recognize and remember, that PARP is a recognized sensor of DNA damage, and it's a protein that accumulates when you have a single stranded break. This protein accumulates and then repairs that particular single stranded break, and the cell survives, which is what you want to happen in the normal cell. But in the cancer cell, you don't want the cell to survive, you want that cancer cell to die. And so, when a single stranded break happens in a cancer cell, and that happens all the time because cancers uh, create these kinds of aberrant alterations in themselves, then that particular cancer cell, if it is given PARP inhibition, that repair that is going on will be inhibited and the fork will stay as it is, and it will not, therefore, there won't be cell survival, there'll be cell death because it's not going to work. Now, the thing is that when you have a cancer cell which has a specific genetic alteration, which is BRCA1, BRCA2, which are part of the homologous recombinant recovery pathway, repair pathways, these tumor suppressor genes basically repair this kind of collapsed fork. But if you have a mutation in this, then this collapsed fork will not be repaired. This collapsed fork is because you inhibited PARP to begin with. So that what will happen is that in cancer cells who have BRCA1 and BRCA2, okay, this will be corrected. But in those who don't have, who have a genetic alteration over here, this fork will collapse. And instead of cell survival, there'll be cell death. So it's a double whammy that takes place. That is the basic concept of PARP gamma inhibition in cancer biology as such. And there have been many trials now in prostate cancer, starting with this one, in which what they did was they gave patients olaparib, a PARP gamma inhibitor, to those patients who had BRCA1, BRCA2, either germline or somatic inhibition. And they found that those patients who carried a lot of these alterations responded to this PARP gamma inhibition much more than compared to those who did not have these biomarkers. Again, it goes to the biology of it. It is not clean completely because there are some patients who did not respond to this particular drug, even when they carried these genetic defects as such. And so those markers resulted in progression-free survival and overall survival being better in those patients who had these genomic and genetic abnormalities. This phase two trial was then replicated in a phase three, much larger way called the Profound trial, which showed the same thing, that if you took castrate resistant prostate cancer patients and who had these genetic abnormalities, and you treated them with this PARP gamma inhibitor and looked at their radiographic progression free survival and overall survival over time, comparing it to other treatments, the outcomes were superior. As you can see in the blue curve over here, people lived longer with this. A newer drug called rucaparib also shows the same, wherein if you give this PARP gamma inhibitor, you do have better survival in those patients who carry this particular mutation in the BRCA1, BRCA2 genes. Now, here's the problem with this: they live longer than the other treatment, and their survival is better. But you will see that in these survival curves, they are failing. There is primary resistance. Some of them don't even have any effect despite carrying this genomic abnormality. And others over time initially respond and fail. So that there is both primary and secondary resistance. And biomarker research is trying to find out why, because we said that if you have a patient with this kind of abnormality, if you do PARP gamma inhibition in that, and there is that abnormality which cannot repair this problem over here, then downstream the patient should the cell should not survive. It will die. That's what you want to see. The problem over here is that if the break is in one allele, and not that's not taken into account, and the other allele is fine, that gene copy is enough to recover and reverse and cause resistance to this PARP gamma inhibition, unfortunately. And that is what we keep seeing all the time in other tumor types. When there is loss of heterozygosity, negative or positive, that can impact in ovarian and breast cancer, which are the other two tumor types where we give PARP gamma inhibition in patients who carry BRCA1, BRCA2 gene defects. The outcomes can be different, and that is the problem that we are facing in the clinics using a targeted therapy. Unfortunately, it tells us that we have to develop biomarkers and use them better, and that's the kind of report we get in the clinic. In the clinic, when a patient comes to us, we get to see this. Here's a very popular genomic lab, which commercial lab, which many academic centers use. They report something like this patient has a BRCA2 copy number loss. Then they say this is going to be sensitive to these drugs. But the reality is, they did not take into account whether the BRCA mutation is monoallelic, biallelic, there's a gene copy available to mend that. They simply say that BRCA2 copy number loss is 1.69 fold. Well, you should have two copies, so 1.69 is less, but there is a single copy which hasn't been investigated, which may be still functional, and that will repair that defect that you are trying to correct in the first place. But we use it and we cause actually more harm in the patient ultimately by doing this kind of thing, but we don't have a better good sense of biomarkers. So let's talk about biomarker science and landscapes. This is how a prostate cancer patient with metastases looks. So we can actually poke one of these dark spots lesions and take a biopsy out of it and sequence it for BRCA1, BRCA2, or other genomic actors. And that's what we have done in the past. We did a prospective trial in which we looked at all of this and found that because it's bone, 1/4 of the time, no matter what method we use, we do not get to know what the DNA of the cancer genome is, because it's bone, it has to be decalcified. And no matter how well we do it, biopsying metastases in prostate cancer is very difficult. In advanced stages, it is very difficult anyway, because we have problems over there in sampling, and it's an invasive procedure. So that brings us, how do we develop biomarkers? And we have published this extensively. We have published Wnt beta-catenin pathway and cell cycle proliferation genes to be upregulated and causing a resistance to treatments from solid biopsies. But because we can't do that very often, we have to go liquid. And so that's where the world has gone in the last 5, 7 years in lung cancer, in melanoma, in breast cancer, and many other tumor types, including this one. It gives us a lot of sampling chance because technology has progressed rapidly, that we can look at in the blood or the liquid biopsy genomic alterations, epigenomic alterations, transcriptomic, lipidogenic, and protein proteomic alterations, and then integrate them for an answer of the kind of the BRCA1, BRCA2 example I was giving, so that we can taper our medicines better based on a signal from these biomarkers. And these applications, therefore, range in liquid biopsy from all the way from cancer early detection to after giving treatments, detection of minimal residual disease. Now, in early detection and minimal residual disease, the gene copies or the altered protein or the altered transcriptome is going to be very less in abundance in the blood, which is where bioengineering ultra-sensitive tools are needed more and more to go to the next generation of liquid biopsy or the third generation of liquid biopsies in the future. But in the advanced disease, the copy of genes are far more, and it can be tailored to the signal of the treatment that we are trying to seek. So I'll give you some examples about that. Now, before I give you those examples, while you can do all of this in liquid biopsy, there are some challenges to that also. And the challenges are, you want to look at the gene copy signals that come from the tumor. You don't want to look at something which is mutational as a fact of age-related clonal hematopoiesis, and you have to differentiate that from actually what's coming from the tumor. This CHIP, or clonal hematopoiesis of indeterminate significance, is something which has to be mindful of. And the other challenge is that when you take 1 ml of plasma, which is derived from about 3 ml of whole blood, you have about 10 nanograms of, on an average, of cell-free DNA, which is contaminated with germline DNA as well as with tumor-derived DNA. In that 10 nanogram, you have about 3,000 DNA copies, generally speaking. If the mutant or the variant allele that you're looking for is only 1% of that tumor derived DNA, you're looking at most at a chance of 30 DNA copies. So your technology has to be very sharp to pick that signal up for that particular mutant allele that you're after. But if that is not 1% and it is 0.1% or less, you're looking at, in 1 ml of plasma, very good technology to be able to pick up this kind of a signal in that many small number of copies that are available that you're seeking. So this becomes a difficult situation when the number of copies are, or the variant allele frequency is low. One way to deal with that is go down and increase the amount of plasma. The more you increase the plasma, the more number of copies. The problem is you can't bleed the patient that much to get that much plasma and then look at all of this in the most lowest abundant variant allele that you're after. So this becomes a challenge. And those are one of the challenges of next generation sequencing in the blood, where we again need bioengineering tools which are far more sensitive that can go down that path. In general, NGS is done this way. You have a patient whose in whom blood is collected and cell-free DNA is purified. And after that, the patient undergoes adapters along with UMIs and ligases that are undergoing that in the library prep. Then amplification happens. And after that, you get your FASTQ files, which are then referenced to a reference genome, and you get your structural variants of interest. That report is then spit out into the molecular tumor board of a clinic, and we start looking at this, and therefore we make our decisions. Now, here's the problem with this. You can do all of that in the molecular tumor board and do all of this. The problem is when you have a vendor which has this whole work flow pipeline, when you go to one vendor versus the other, it's a black box of bioinformatics proprietary, which they don't tell you how they're doing the call rates. They also don't tell you during the making of the libraries what that process is, which can introduce artifacts into the process, as in false positives and negatives. So both sensitivity and specificity can get impacted. In fact, there was a publication recently in which they took 5 different commercial vendors who had targeted gene panel sizes between 400 and between 100 and 600 genes, looking at mutation types of single nucleotide variants, indels, copy number alterations, and fusions by different capture processes, both most of which were hybrid capture, except for this vendor, which was doing PCR, and looked at the amount of cell-free DNA that you need for looking at specific mutations that they gave these vendors to look at. The results of this was that all 5 assays demonstrated a very high sensitivity when the variant allele fraction was 0.5% or 1%. Remember the calculations we were doing in the previous slide? But and when the the DNA input in the cell-free DNA was between 30 and 50. When this went down to 10 nanograms, it started having problems in the sensitivity and the specificity, and specifically for those variants which had a very low frequency to begin with as such. Then it starts impacting. Now you take these calls into the clinic and you start using that, and you could go wrong. And so again, there are challenges with this emerging technology, but they are used for the most part in the most common variants that we look at as such. So we did this process in trying to molecularly profile prostate cancer from in the advanced stages and different stages of progression. Looking at all these challenges, we tried to create that opportunity to understand biology a little better. Uh, there were about 70 patients in the metastatic hormone sensitive stage. There were another 30 patients who had undergone androgen deprivation therapy. We wanted to look at the molecular profile in the ctDNA part in the liquid biopsies of those patients as to the effect of the hormones. Then we looked at a separate cohort of 75 patients and another 70 patients who were failing androgen deprivation therapy, and then basically profiled their liquid biopsies for circulating tumor DNA molecular actors. Here is what we found. First of all, as you go forward, the ctDNA fraction keeps rising as diseases progress from hormone sensitive to castrate resistant, both for cell-free DNA and circulating tumor DNA. Second of all, when you look at the most important gene in castrate resistant disease, which is androgen receptor, while in hormone sensitive disease, there is hardly any mutational burden that you can capture. In castrate resistant disease, in the more advanced stages, mutations start to appear much more commonly. The mutations are at different exons, and all of these are potential biomarkers now that you can detect and you can target. The mutations are not just in the androgen receptor gene, they're also upstream and downstream to the androgen receptor that you can detect in variant allele frequencies. And these have meaning in terms of outcomes, clinical outcomes. If you have these mutations, these red lines show poor survival compared to if you don't have these mutational alterations. Same way for androgen receptor amplification. If you have that, that's bad. So we find these signals in the blood, but it is really not just about one gene. It is the repertoire of what is being thrown by the cancer cell into the blood that you want to capture. So if you look at patients who have got hormone sensitive disease, in the number of genes that we looked at a panel of over 150 genes, and I'm only relaying the top 50 over here or 40 over here. In untreated hormone sensitive stage patients, these are the kinds of mutations in TP53 androgen receptor, not just mutations, but copy number alterations, fusions, etc., that you can detect in the blood of these patients. As you progress, after treatment, some of them go down. As you progress from hormone sensitive to castrate resistant, the slide becomes far more colorful. On the right-hand side, you will see an accumulation of alterations that you can easily capture in the blood. And all of these are potential signals that you can therefore harness for either treatment or monitoring over time with a clinical outcome of your choice as such that you want to do. Now, come back a minute to BRCA-based genomics over here. Over here is the row for BRCA2. In hormone sensitive, you hardly have any alterations, only a handful of patients. As you go forward in advancing stages, the number of alterations in the somatic alterations in the blood in BRCA2 become more and more relevant. In other words, they become more ready for that olaparib and PARP gamma inhibition, if you can get a patient of that kind. So we did this. These are my colleagues in Australia who took our data set and combined it with theirs, Dr. Azad and Dr. Fetke. And we looked at what I was saying earlier, that are these BRCA mutations monoallelic, biallelic? What is the impact of that over time? So they took a look at over 500, 600 patients and found that, first of all, somatic and germline, not everyone who has a germline will have a somatic one. There are about 10%, 13% patients who carry germline mutations, and the rest are all somatic aberrations. Homozygous and heterozygous copy loss matters in BRCA targeting. And this study told us that about a quarter patients will have homozygous loss. Those are the ones who potentially could benefit most from PARP gamma inhibition if you know that in your liquid biopsy. But currently, the state of the art is that we do not know that. And again, monoallelic and biallelic losses matter. These study patients were not given PARP gamma inhibition. They were given novel hormonal treatments. But what we are seeing over here is that based on the degree of alterations, outcomes will be different, and treatments will outcomes, not just survival outcomes, will be different. So we need to know this much more better when we treat our patients, not just for BRCA1 and BRCA2. In the liquid biopsy, we have the ability now to monitor disease after chemotherapy. When we give chemotherapy to patients and measure their ctDNA based profiling before and after, we see that in responding patients, circulating tumor DNA alterations go down as opposed to circulating tumor DNA alterations which don't change in those who don't respond. So we must be doing something right for these patients as such. The question is, what are the nature of those alterations that we need to follow that could become biomarkers in the future as such? Same way over here, the nature in terms of what type of alterations we see in responding and non-responding patients. There are different types. Androgen receptor amplification goes down in responders. It does not in non-responders. Same way, ATM alterations go down. It does not in ATM, BRCA1, BRCA2, PTEN, so on and so forth. All of these become relevant to measure and derive a formula that we can then follow for patients in the future. And so it's not just one gene, it's multiple genes that change. So we need to mix them together into an algorithm. And why is that important? Because cancer is heterogeneous. It's not just one tumor gene that we are treating that is deciding the fate and biology of that cancer. These are multiple pathways in the advanced stages that are aberrant, and we are trying to seek out a common denominator. So we created a multi-gene score of these alterations before and after treatment, and then tried to study the outcome based on multi-gene profiling in patients who were treated with this regular drug. And before and after, we see the differences in many of these patients who are responding and non-responding, so that we created that formula. And when we look at that formula of an 11 gene score, those patients who have a low score are based on these alterations do well with this treatment, while those who have more aberrant scores, they do poorly. And this is the kind of convergent sciences where biomath is being applied to genomic sciences, is being applied to liquid biopsy technologies to bring to the patient. This is something that is not common for just us in prostate, but I'll give you an example in breast cancer where this has worked and become state of the art to be applied in the clinic. It's not just about DNA. We also look at the epigenomics part. Like the problem with DNA is that it could be coming from white cells, it could be coming from age related problems. Epigenomics is very tissue specific for the cancer. So, prostate cancer progression we know is regulated by a coordinated spectrum of these epigenetic alterations. In the blood, we again wanted to look at those spectrum of alterations from early stage to advanced stages to find out the different stages which are state specific epigenomic changes that again to use as biomarkers for either minimal residual disease monitoring or early detection, etc. And so one of our colleagues at Moffitt Cancer Institute, Dr. Liang Wang and his team and our lab worked together on this project in which we collected liquid biopsies from over 100 patients and purified their cell-free DNA, applied Twist Biosciences enzymatic methyl-seq for 411 genes, which are specific for tumor, prostate tumor biology at the methylation islands, CPG methylation islands of these promoter. So we had about 3,000 probes looking into it. And then after doing analysis by aligning it to reference genomes, here is what we found. In these patients, if you look at the deep differentially methylated regions in different stages of progression, look at the early stage, the middle, the blue is local prostate cancer, the green is hormone sensitive, castrate resistant is the red one. And what you see is that the differentially methylated target regions keep increasing with the progression of cancer. And those are again potential biomarkers of interest to us that is going with aberrant biology that we need to harness again. We've also looked at proteomics, and Dr. Tan at our place in his lab has looked at multiplexing from proteins in blood by using high throughput technology, which was largely from Olink, where in a dual antibody tagged NGS based protein detection in blood is what we are trying to do, which by an assay called the proximity extension assay, wherein hybridization takes place and extension is followed. Two probes for each protein are hybridized. If they recognize it, that is then extended. And once that's amplified, it goes through normal NGS pipelines to detect those proteins. So we took 3,000 proteins in different stages of cancer again and looked at the characteristics of protein profiling in the blood of these 3,000 proteins in early and advanced stages as such. And what we find over there is, once again, in local stage, there is a very, very unique profile of local stage prostate cancer patients, proteins that are upexpressed, which is very different from castrate resistant and very different from hormone sensitive. So that at each stage, we have epigenomic markers, we have protein biomarkers, which are unique to that stage and need to be zeroed down on to make algorithms potentially or to study tumor biology from. So we integrate all of this right now from different omic platforms. And we have looked at machine learning in trying to make neural networks of these multitude of analytes and putting them together to capture the heterogeneity for clinical outcomes. And one of our publications is out over here under review, which was very favorably received with this. Ultimately, when you have this algorithm, you have to test it prospectively. It's not done yet. You just have a discovery signal. And this is an example in breast cancer, how long it can take to do that. In breast cancer, you have a score that is generated based on the expression patterns of these genes. And these are mostly estrogen receptor and cell cycle proliferation genes. That was a marker that came about in 2008. Even before that, I think Dennis Slaman was from here in his lab, it started. in the late 1990s. And basically, it morphed into this Oncotype DX panel that was based on these genes, in which a score is given to the expression pattern of each patient's each gene. And based on that, treatments are decided, so that if a certain gene, a patient has a score which is low, don't give that patient any chemotherapy because she doesn't deserve it. If the score is high, then give that patient. And if it's in between, randomize and compare who will actually benefit. It took the biomarker development into prospective clinical trials for 10 years to come to this decision, but now it is standard of care for hormone receptor positive, HER2 negative breast cancer patients who are being decided for one treatment over the other. And that's the pipeline, therefore, that takes place in terms of developing in and impacting clinical care. We've also looked at microRNA. Utkan and Prima and others in the lab here are and working on this right now, where we had an observation back in 2014 that microRNA 1290 and 375 are upregulated in bad prognosis prostate cancer patients in the blood. We did functional studies in vivo, and that seconded that observation, and that became the course of our investigation, that can you pick this up in extracellular vesicles or in plasma free floating also. That's the subject of two R01s that are ongoing, one of which is over here at Stanford that we are working on. Very difficult to do this by gene array or RNA sequencing, and qRT-PCR, it's laborious. You can't multiplex all these candidates. So we are in one of our R01s with Andrew Smith at UIUC, looking at the microRNA detection, looking at single molecule following, in which we take drops of blood from the finger into a filter pad and extract the RNA from there. And then after extracting the RNA with quantum dots, try to detect that particular signal after normalization. Now, that normalization is a big chore that we are still trying to achieve. I'm going to show you the concept behind that, as well as something that Dr. Um, Cunningham showed you last week in a small capturing video, as in just the concept behind it.
Using 3 molecular techniques, cancer patients can receive accurate results from just a few drops of blood. Then, by immersing part of the filter paper, miRNA can be collected. In the single molecule flow technique, miRNAs, if present in patient blood drop, are extended using rolling circle amplification, employing circular DNA and DNA polymerase. The extended miRNAs are labeled with multicolored dyes. Flow cytometer multispectral analysis is used to detect the presence and number of numerous miRNA sequences at the same time. In the single molecule counting technique, miRNAs are extended by using the rolling circle amplification process. The extended miRNAs are captured on a DNA functionalized cover slip and labeled with fluorescent dyes. Molecular imaging and counting is carried out under a microscope. This approach is particularly useful for simplified instruments that can work at the point of care. In the photonic crystal-enhanced quantum dot emission technique, miRNAs are hybridized with photonic crystal surface-bound capture probes. The hybridized miRNAs are labeled by gold nanoparticles. The photonic crystal surface-bound miRNA probe complex is studied by employing biosensor microscopy. The molecules can be counted with very inexpensive and portable instruments.
So that's what we are doing. And part of that is this amplification process that is the rolling circular amplification, an old technique being used for teaching a new evaluation for clinical applications as such. And like I said, it's very difficult right now. We are normalizing it, but we have gotten to the point that we are quite confident that we've got our normalization controls for measuring these small, abundant molecules of interest as such. Now, all of this is biomarker work, it's bioengineering, it's all other kinds of things. There was an editorial in the New England Journal of Medicine a few weeks back, which said, your money or your life. And the reason over there was that all these drugs that we use are very, very expensive. These are blockbuster drugs. And we're using them in every patient without really targeting more precisely because we don't have that biomarker knowledge. So that while we develop that knowledge, how do we really use it in the meantime? And for that, what we do is that all these different drugs that we have, we do what we are calling cost effectiveness research. What's the bang for the buck in terms of finding out whether the amount of money that we give, the drugs that we give to our patients and the cost that is involved with that, does it buy them longevity of life and quality of life? That's based on a partition survival analysis that cost effectiveness research is based on, where it takes into account dynamic states like is the patient progression free, is the patient progressing, is the patient dead, gives a number to their quality of life, gives a number, calculates a mathematical model of that, and then goes on and tries to look at the value that was added for the money that was put in over there. Because we don't have biomarkers, we don't have head-to-head trials as to find out which drug to give to which particular patient as such. And when we did that, we find that in the past, when we used to give androgen deprivation therapy alone, the quality of associated life years was pretty decent. By adding everything that we've added in the last 7 years, the quality goes, associated life years goes up, but it goes up at an expense which can become exorbitant. In other words, you can give $1 million and buy a few months more of life, as well as a few months more of quality of life. And where's the balance over there? Ultimately, we want to treat our patients, make them live longer, make them live healthier. But if we can do that by biomarker research and bioengineering, that'll be much more better and precise compared to what we are doing right now, wherein we are pouring in millions of dollars for very incremental sort of gains overall as such. And so these are different facets of science we are trying to bring converge together. And that's what the National Academies report has even sort of endorsed as such, that facilitating transdisciplinary integration of life sciences, physical sciences, engineering and beyond is important. And that the goal of merging expertise to address these complex problems, it's not new. But at the heart of the current momentum for convergence is the realization that physical and biological sciences can benefit from being fully integrated so that we give the best product for our patients and both research and science as well. And so we use cancer biomarkers, we fuse them with bioengineering, we fuse them with natural language processing AI, we get health economics outcome by way of cost effectiveness research, and then we do the clinical trials to put them and integrate together with the patient being in the center of all of this. And so if I've tried to convey a message over here today, it is that multiple facets are involved in delivering medicine in a more precise way. Capturing biology early is critical, and making it cost effective is just as critical. Clinical trials need to be done prospectively, which will have to be validated. And of course, cost effectiveness is going to be part of that equation. So I'm going to stop over there. There are many collaborators who have, over the last 10 years, produced this data with us. We were very lucky to have that, and we continue to have that over here, including with your labs over here. And I hope that we can only increase that in time. I'll stop over there. Thank you very much for your time. Hope I finished in time.
Any questions from the audience here? There is one questions from the Zoom audience. There are like 20 plus people in the Zooms. They enjoyed it so much for your talk. Thank you so much, Dr. Kohli. And the first question is from Parag. He asked, do you notice synergies between the different ones when analyzed together? Do you notice synergies between the different ones when analyzed together?
Synergies of
Yeah.
of which part?
Yeah, correct. Maybe can you unmute yourself or try?
Synergies between what? Sorry.
Omics, between omics. Yes.
So yes, they, I think at this point in
Sorry.
time, at this point in time, we don't have a clear indication which is the better omic platform to use. I would suggest to being completely open-minded and agnostic of the omic platform, as long as the analytical validity of the platform is good. You can develop a biomarker. My own feeling is that if the analytic platform validity is good, whether it is genomic fused with proteomic or proteogenomic biomarkers, or it is genomic with lipidomics, which is one of our patents that we are filing this week, in which we took the lipid biomarkers in prostate cancer patients and fuse them with the genomic alterations to make a multi-omic model to predict clinical outcomes in hormone-sensitive and castrate-resistant disease. As long as the analytical validity is there for these platforms, you can, in my view, go agnostic of the platform and fuse them together for a clinical value output. So in other words, analytical validity leading to clinical utility should be agnostic of omic platforms is my view, at least.
Correct said. Very interesting. Thank you. Is there any? So there's a question from Daniel Cap. He asked, have you considered integrating molecular imaging such as PSMA PET to follow patients and predict response?
That's a very relevant question nowadays because PSMA PET is being used very often in advanced stages and also in early stages after PSA relapse takes place from after the failure of primary prostate treatments. So we are in a real world setting collecting all their samples, being very, very, very cognizant of the pre-analytical variables that can introduce bias. We process these samples within 1 hour into -80, and then we take those and study the same things before and after PSMA scans in terms of changing molecular biology. Yes, we are considering to, in a short summary answer to your question, that is relevant and that should be studied at the molecular level for all of these new age radiopharmaceutical scans that are emerging for prostate cancer care, in fact, for any tumor type. So yes, thanks for the question.
So there's no more current open questions on Zoom. So, but I have a question for you, Dr. Kohli. So it is interesting that you combine all the clinical data, like to the cost analysis. So just wondering, just a quick question for the first questions. Is it just within the US that you did all of the data that you showed is just within the US for the qualities and the cost that the cost analysis that you did?
Yes, unfortunately, the cost analysis is a big headache in the US because every system insurance companies carry their own costs. And every P&T or pharmaceutical and therapeutic committee of every hospital has a different acquisition cost. Medicare costs are different. Private insurance reimbursement is different. Medicare reimbursement is different. So what we did was we looked at these 7,800 patients in these published clinical trials. And then we simulated the cost from VA, Federal Supply Scheme, VA FSS, where the costs are uniform. That's the only uniform system in the US which can give us costs, which can be the inputs for our cost-effective analysis then. So we could not do it for the private or university settings. It is totally limited in the US to the VA system only, and it's not possible. It is possible in Europe to do that. NICE does that, NICE. They do that because they have a uniform acquisition cost, which can then be the input variables as such. Not so in the US, other than these standard systems like the government federal supply.
So, a follow up on that questions though, I'm interested in knowing that if the choice of cocktails, like chemotherapy cocktails, will be decided depends on depending on the qualities, or how would a clinician decide on like a treatment, a regimens that they will give to the patients?
In my view, the best way to do that is by biology and not by cost. Of course, cost effectiveness analysis comes because we don't have tumor markers. So in order to develop the tumor markers, which are relevant for each stage of cancer or each cancer for that matter, and then also whether they're relevant to a treatment drug effect, I think it's important to go to biosensors that can pick these things up, whatever they may be: DNA, methylation sequences, protein, lipids, metabolomes, whatever they are. As long as biosensors can pick that up, and that too probably pick it up in a way where it is reproducible and can match that this signal matches a certain drug efficacy. That's the kind of paradigm we should be actually doing. Until that time, we have no other way other than doing cost effective analysis, as in saying that this drug is better than that drug because you pay less, but you will get your quality of life and longevity of life, which will be slightly less than the other one, and it's by a measure of that much. So you decide which is the best way for you. Um, the median income of a family of four in the US is about $80,000. If somebody, God forbid, comes back down with cancer, how can these blockbuster drugs be paid for then? That's a relevant question that we have to ask all the time, either by biomarker research or by cost effectiveness analysis. That's the take we go with. Yeah.
In terms of the paper diagnostics, how stable the RNAs in your experience? Very stable when dried form.
Absolutely. So we collect the patients. We send the instrument home with the patient. They collect the 2 drops of blood. Then they put it into a FedEx envelope, and then it goes to the lab over the next 24 hours. And then it's stored over there for a few days so that they can batch it together. And then when they have been able to, using basically Trizol to extract and purify, the stability and the amount is very, very consistently stable that you can get. Then you can probe that for whatever target you have. But we've done that now. Andrew Smith and his lab has done this for about 4 years now. And we've done it in about 500 samples out of from 100 patients. And we're getting the same signal again and again without any RNA stabilizers, just air dried. Yeah. So it seems to be the case. Now, the question is, when you have a target in mind to understand the abundance of that molecule, the normalization with qPCR and the standard controls that you need over there to see whether the signal for the target is high or low or medium, whatever it is, that's the step that has become the bottleneck for some time for us. And that's where we are going through one piece at a time right now. Yeah.
Have you looked at the correlation of the imaging features on the radiomic side of things and correlating the the liquid biopsy aspects of it to see if you can, predict progression, radiological progression using some of these markers?
And so for that,
Sorry, Dr. Kohli.
and for that, like the previous question of lutetium PSMA PET scans and other imaging techniques, these are so new right now that we are literally in real time collecting patient samples on these patients who are undergoing these. Oh, yeah. So all of them, wherever we collect serial samples, we collect the information whether it was done before or after imaging, and whether that and before and after treatment, both. and because we want to know the response based on that. And then the second time of the collection, again, the imaging, so that we are trying to see whether the molecules correlate with the image as such also. And the what molecules? Total cell-free DNA, just the coarse measure to begin with. Then when we finish the sequencing, the ctDNA. I don't have those answers yet, but the point is that we are collecting that kind of a sample repository to answer those questions, because technology has progressed suddenly and we're still trying to wrap our minds around all of these technologies to know how to apply them. That's where we are. But that's a very good question, relevant question, actually.
Any more questions? Probably I can ask like one last questions before we wrap up. You showed data of like mutations. A lot of them, like I think you highlight like TP53, like BRCA. So just wondering if you if you had to say one thing of like mutations that is very hard or like being studied right now to see the effect of a different treatment, or let's say early cancer detections not on the treatment regimens, what would be like top 2 or top 3 genes that you would say would be interesting to look at?
So one of the things in prostate cancer, if you're talking about early detection, as in patients with not diagnosed yet with cancer, and you're trying to focus over there, remember the point I was trying to make, that the abundant number of aberrant molecules is going to be very low. So you have to have a very high sensitivity to biosensor to begin with. Number one. Number two, you need to know your targets, which is what you're asking. What kind of this thing? Now, 90% of early prostate cancers have got a GST-Pi1 alteration. You can detect that. You can detect also temporis erg, which is a fusion molecule which is found. The data is already public. This is there already. The point is not that what the targets are. The point is, if you detect them, what does it mean in a particular patient? Because just like PSA detects prostate cancer, which is generally more indolent than those cancers which are aggressive. You want the molecules which detect aggressive biology upfront. And that you will have to sit down to look at the biology of Gleason's 8, 9, and 10. And this is all very well published as to the kinds of genes and then what quantity they are altered in. Both of those metrics will have to be devised. Now, that's just genes. You could argue, why genes? Why not the epigenome? Why not the protein? And that's what we are trying to do over here in our example that I showed you about proteomics. We are going for the proteomics, and we find that out of all the 3,000 protein molecules that we looked at, there were 16 that were very unique to early detection, local stage prostate cancer. And of those 16, there were at least 10 which were associated with Gleason's 8, 9, and 10. Then we took those molecules and studied them in a second serial sample after radical prostatectomy was done. And some of them were still present. What we don't have is what happened to these patients over time. That takes time to collect. So it's one of those one step at a time processes. So that's where we are with that.
Thank you so much, Dr. Kohli, for great presentations. And thank you, everyone, for coming here and joining us. Thank you.